Hello, a very good evening and good afternoon to one and all who has joined us. I am Ganesh Kumar Viswanathan. I am a faculty at the Department of Hematology at AIIMS Delhi, and it's my pleasure to welcome you all to this journal club and journal scan on behalf of Image Society. Uh, we have a speaker, Dr. Akshaya Mondlai, who is a consultant hematopathologist and section head, Department of Hematopathology and Flow Cytometry at Agilus Diagnostics Reference Lab at Mumbai. Dr. Akshaya will present the article for the journal club today. And in the experts, we have well-known experts in the panel today. We have with us Dr. Anil Handu. Sir is a senior consultant hematologist and principal director and HOD of Hospital Lab Services at Max Healthcare Institute Limited and BLK Max Super Specialty Hospital at New Delhi. And we have Dr. Noemi Pugh, who is a hematologist at the University Hospital of Salamanca at Spain, and the first author of this article. And along with me, I have Dr. Sumit Mirk, who is an associate professor looking after the adult hematolymphoid and BMT at ACTREC Tata Memorial Center, Mumbai. And we have Dr. Nitin Yashas, medical oncologist and hemato-oncologist at Manipal Hospital, Bengaluru. So without further ado, we'll dive into the JC today, and over to you, Dr. Akshaya.
Thank you, sir, for the kind introduction. I'll just share my screen. So good evening, everyone. Thank you, Image, for giving me this opportunity to present this journal club, that too in front of the first author herself.
Hello, Dr. Akshaya.
Yes, hello.
Madam, we won't be able to see in the full screen. If you can just full screen and then you can share again, ma'am. Presentation.
One second.
You can stop share and just...
Is it better now?
Just stop share and just slides, open the slides again and first put it in full screen and then share it. Few minutes before you did, na?
Yeah. Trying to do that only.
Yes, ma'am. Working.
So topic for today's JC is measurable residual disease by mass spectrometry and next generation flow cytometry to assess treatment response in myeloma. This was published in Journal Club, and this is the study of Dr. Naomi Puig and her team at Spanish Myeloma Center. So we all know that even in some patients with complete response, a small number of tumor plasma cells, MRD, may always remain, and it is detectable only by very sensitive methods. And absence of MRD is associated with longer progression-free and overall survival probabilities. The same was documented in a large meta-analysis by Dr. Munshi et al. As well. In 2016, IMWG working group has incorporated myeloma MRD into the criteria and has defined the response criteria for MRD negativity cutoff as 10 to the power minus 5. So various techniques are there to monitor multiple myeloma disease activity in bone marrow and serum. In the cell-based technique, we can do it with IHC with very low sensitivity, or flow cytometry and NGS with near comparable sensitivity, or we can detect M protein in serum with help of SPIFE or the novel technique of mass spectrometry. Just a brief point about next generation flow cytometry. So it uses the SOP developed by Euroflow Consortium, which permits acquisition of more than 10 to the power 7 events, and its sensitivity is approximately 10 to the power minus 6. Euroflow has proposed 8-color 2-tube panel, in which tube 1 is used to identify abnormal plasma cells. The pink color ones are abnormal plasma cells, which is based on overexpression or aberrant expression of some markers like CD117 and 56, or underexpression of the normal plasma cell markers, which are 38, 45, 19, 27, and 81. The second tube has cytoplasmic kappa and lambda light chain, and it helps to demonstrate clonality in the previously identified abnormal plasma cells. So the advantages of this method is it's very fast and comparatively economical, but with same sensitivity as that of NGS, and it provides overall assessment of sample quality. Like we can also assess if it was a hemodiluted sample based on mast cell percentage and other thing. The limitation is it cannot be done on stored sample, and it has limited use in extramedullary disease and focal or patchy disease. Coming to the second thing, that's mass spectrometry for evaluation of M protein. And IMWG has given some recommendation recently regarding mass spectrometry, and have recommended use of intact light chain multi-TOF mass spectrometry for clinical assessment of patients as well as in trials. Mass spectrometry is an emerging approach for detecting, classifying, and quantifying M proteins in plasma cells. So first of all, the sample is purified, immunoglobulins are purified, and it is mixed with a matrix into a multi-TOF plate. This plate is then placed in the vacuum chamber of the multi-TOF analyzer. So what is multi-TOF? It is matrix-assisted laser desorption ionization time of flight assay. So let's see what's that. This is a diagrammatical representation for same. Here the sample plate is kept. This is the ion source. Here electrostatic field is applied. This is the flight tube, at the end of which is a detector, and it is connected with a transient recorder, and then the data is analyzed. So when laser beam passes into the matrix plus sample multi-TOF plate, it converts samples into gaseous ions, and electric fields helps in accelerating it. Then the ions travel into this flight tube. The lightest ion will arrive the detector at first, and based on it, the mass of the molecular mass of the particle is calculated, and this technique helps in measuring the mass to charge ratio for individual monoclonal light chain, which is very patient specific and could be used for personalized disease monitoring. At the end of it, we get something like this. This is a normal sample in which we can see polyclonal kappa and lambda light chain, while this is the abnormal sample where we can see a M spike with a background of polyclonal, with a polyclonal background, sorry. So the advantages of this method is it's more sensitive than traditional IFE. It is minimally invasive, can be done in serum, and it can differentiate between endogenous M protein and therapeutic M protein antibodies. The therapeutic monoclonal antibodies like daratumumab, because both of them will have different masses to charge ratio. And it can also identify the N-glycolization of light chain, which is a risk factor for MGUS progression, AL amyloidosis, and cold agglutinin disease. The disadvantages being the false positive results are due to delayed clearance of M protein from serum, and it has limited global availability and the cost, of course. So coming to the paper, just an overview. Bone marrow MRD assessment has its limitation. It's invasive and affects patient compliance, and also it only gives us assessment of a single random site and misses the spatial heterogeneity of the multiple myeloma disease. Quantitative immunoprecipitation mass spectrometry, QIP-MS, on the other hand, detects M protein in serum and identifies MRD even in patient with complete response. And there are two broadly used methods for mass spectrometry. One is MassFix, which was developed by Mayo Clinic, and second one is XENT. It is developed by Binding Site, which is currently a part of Thermo Fisher Scientific now. So both of these methods have found to outperform serum immunofixation in detecting M protein. So Dr. Pooj et al. Have compared this extend method of QIP in serum and bone marrow MRD assessment by next generation flow cytometry in transplant eligible newly diagnosed multiple myeloma patients. And analyzing serial paired peripheral blood and bone marrow samples from patients from GEM 2012 MEN OS and GEM 2014 main clinical studies, the authors have provided important information about complementarity between peripheral blood and bone marrow MRD assessment and potential of mass spectrometry as tool for disease monitoring and its progression. So coming to the GEM 2012 MEN-OS study, here newly diagnosed transplant eligible multiple myeloma patients were taken, given VRD induction followed by transplant followed by consolidation, and MRD was assessed post-induction, post-consolidation, post-transplant and post-consolidation. While in GEM 2014 main study, which was the maintenance trial post-transplant, patients were randomized to receive lenalidomide dexamethasone with and without ixazomib for 2 to 5 years, depending on the status after first 2 years. MRD was assessed after first 2 years, and if it was MRD negative, treatment was stopped. While if at the end of 2 year MRD was positive, maintenance was continued for 3 years. Annual assessment of MRD was done for 5 years. So serum samples were simultaneously obtained at all the time points of MRD evaluation and were retrospectively analyzed by QIP-MS using the exempt immunoglobulin isotype GAM assay, which we have just described, but excluding the free light chain. So here the immunoglobulins were initially purified from serum using the paramagnetic beads coated with specific polyclonal antibodies and then processed, and the data was analyzed. The cutoff for NGF MRD was considered as 2 into 10 to the power minus 6. So first, the authors have described the concordance and disconcordance between mass spectrometry and the traditional methods of M protein detection. So here, the shades of gray are representing the agreement seen between IFE and mass spectrometry, while the shades of red are giving us the disagreement. So QIP mass spectrometry was more sensitive than SPE and was able to identify monoclonal protein in up to 15% of the SPE negative patients. And among the IFE negative patient IFE negative patient, up to 15% mass spectrometry was able to identify the negative patient, and in the negative patient too, it was able to identify 2 subset with distinct progression-free survival. So in another study by Dr. Naomi, they have shown that IFE is not able to discriminate between 2 different subgroups of patient at all time points. The authors have also described the concordance and disconcordance between mass spectrometry and NGF at all the pre-established treatment time points. And these are the total positive cases by flow cytometry at all the time points. And these are the total cases by mass spectrometry. And we can clearly see that NGF has detected MRD more frequently, 69% versus 59, 50 versus 42, 44 versus 34, and 29 versus 24%. So NGF has detected MRD more frequently than mass spectrometry, both during the active disease and treatment. And the same thing is depicted in pie chart. Here the shades of blue are showing agreement between the 2 assays, and red are showing the disagreement. So agreement was 82% post-induction, 77 and 76% post-transplant and post-consolidation, and 85% post-maintenance. And when NGF was considered as the reference, the negative predictive value post-induction was approximately 65%. The negative predictive value of mass spectrometry post-transplant was approximately 73%. Post-consolidation was again 73%, and post 2 cycles of 2 years of maintenance was 86%. So in another study by Dr. Dispensary et al., the NPV of mass spectrometry, there the method used was mass specs, was found to be a little bit higher, 83%, 90%, and 95% respectively. The concordance between these 2 methods was lowest at the earlier time points. Like in transplant and consolidation, the concordance was just 77%, while after maintenance, it was found to be 85%. The same thing aligns with the findings of Dr. Kubicki et al., where the agreement rose from 61% to 74% after 18 cycles of treatment. Now, coming to the possible reasons of discordance, where flow was negative, but mass spectrometry was positive. Although these cases were low, but they remain constant in all the treatment phase, and it could be due to delayed IgG clearance or the extramedullary disease, or the sample was hemodilute, or it was a patchy disease. And a point to be noted is that in most of the cases which came positive for mass spectrometry and negative for flow, they had plasmacytoma at the time of diagnosis. So similar findings here, approximately 16% disconcordance was seen in Kubicki et al. Study. So discordance were mostly due to increasing. So here you can see all the discordance are mostly because flow is coming positive, NGF is positive, and mass spectrometry is negative. So all the NGF positive cases were pooled and plotted as a log range of MRD independent of the time point, and result of mass spectrometry was analyzed at them. So these are all NGF positive cases. This is the sensitivity log of NGF, and here the pinkish population is mass spectrometry negative and bluish population is showing concordance between the two methods. And we can see that there is a clear increase in this pink population, that is discordance at the lower ranges of MRD. So agreement between flow cytometry and mass spectrometry decreased significantly when flow was at a sensitivity between 10 to the power minus 5 to 10 to the power minus 6. And the disconcordant rate at this later level of sensitivity could represent the limitation of mass spectrometry as an alternative method for evaluating MRD. But here the points to be taken are that only 16% cases are positive by flow also at this small level. And the criteria that IMWG has set is 10 to the power minus 5 for MRD detection. So then moving forward to landmark analysis of progression-free survival in patients in both the trials based on MRD status. So above line is MRD status by mass spectrometry and the below one is by flow cytometry. This is the post-induction, post-transplant, post-consolidation, and post-maintenance. And we can see that there's a good difference in all of the graphs. So both methods are equally able to identify two groups with significantly different progression-free survival, although the p-values and HR hazard ratio have clearly favored the flow cytometry in all cases. The median progression-free survival when testing for positive NGF or mass spectrometry was very similar at each time point, except in maintenance, when median progression-free survival was not reached. The median progression-free survival for both dual negative patient have not been reached at any time point analyzed. Now, in the first trial, GEM 2012 MENOS trial, this is the mass spectrometry and flow cytometric dynamic, which was analyzed. Here, the green population is the one which was negative for both. The red one is, which was negative for all at all the time point for mass spectrometry. The red one denotes which was positive at all the time points. This in graph 1, it is for mass spectrometry, and in graph 2, it is for flow cytometry. And the blue one is when there was a conversion from positive MRD to negative MRD in first plot for mass spectrometry and in second plot for flow cytometry. So here we can see that sustained mass spectrometry or flow cytometric MRD positivity at all the 3 time points is associated with a very significantly shorter progression-free survival, approximately 4 years in both of the studies. Similarly, in main trial, these things were analyzed, and along with these 3 parameters, fourth parameter, that is conversion from MRD negative to MRD positive, which is depicted by purple line, was also assessed. And we can see that converting from negative mass spectrometry to positive mass spectrometry was associated with a very poor outcome, where the median progression-free survival was less than 1 year, while conversion of flow cytometry negative to flow cytometry positive did not significantly differ from sustained positivity. So all the 14 patients converting from flow negative to flow positive, out of them, 7 were between, approximately half of them were between the level of very low MRD, 10 to the power minus 5 to 10 to the power minus 6. Conversion at mass spectrometry level probably reflects a relatively high tumor growth. The same does not apply to flow cytometry conversion from negative to positive. At a very low level, probably impending relapses will not occur until MRD by flow is at a higher level, that is 10 to the power minus 3 or 10 to the power minus 4. Similar observation were found in study of Mai et al. As well. So there are many other studies also which have backed up the data that is presented in this study, like the one with Derman et al. Or Disperenzi et al. Or Mai et al. Just summarizing all the findings. So comparable prognostic value was found between mass spectrometry and flow cytometry at all the time points. Between mass spectrometry and flow cytometry, both of them effectively stratified patients based on progression-free survival. Maintaining and achieving MRD negativity by both method was correlated with a superior progression-free survival. And QIP mass spectrometry re-emergence of MRD strongly predicted imminent clinical progression. So to conclude, in transplant-eligible multiple myeloma patient, MRD by NGF and MS achieve similar prognostic value in single time point assessments and kinetics. Bone marrow MRD assessment still remains the gold standard for prognostication and treatment decision, but mass spectrometry may play a complementary role. Mass spectrometry is promising minimally invasive method for MRD assessment in multiple myeloma, and it offers a valuable tool for improved patient risk stratification and treatment decisions. So this leads us to some questions, that how feasible is incorporation of these two methods in routine testing, that too in a cost constraint settings like India. And what about the global availability of both these methods and harmonization of these assays? And also, what is the impact of mass spectrometry in extramedullary diseases or in focal lesions, which is currently done by imaging studies? So thank you.
Thank you, Dr. Akshay, for the nice presentation and the overview. And now I invite our experts, Dr. Anil Handu sir and Dr. Naimi Pur for the comments and discussion.
Thank you, Dr. Ganesh. And it's indeed a privilege for me to be discussing this particular paper, because obviously we are at the anvil where we are talking so much about the mass spectrometry nowadays, especially in the context of some work which has been done from India as well, especially from Adyar Cancer Institute, where our colleague Dr. Nikita has also done some work on this. Anyway, the first things first, I think, Dr. Akshaya, it was a wonderful presentation. You touched upon most of the stuff very beautifully, and it was very obvious, the pointers which gave out pretty clearly from the presentation, if I may summarize them. Number one, that the mass spectrometry is here to play an important role in the assessment of the disorder of myeloma or plasma cell disorders. Number one. Number two, it has a very important connotation, in the sense that if it is a positive test that we're getting from mass spectrometry, that means, in other words, if I say the positive predictive value seems to be pretty high, though the negative predictive value does not seem to be kind of giving us an important information all the time. So therefore, if there is a positive test, it gives me a very strong correlation with my positive cases in most of the times. Of course, we have seen in conditions where, for example, flow cytometry was kind of negative despite having a positive mass spec positivity of the case. Now, we also know that there are attributable reasons for flow cytometry for us not to give us the correct results as we are expecting out of it. The important aspect here is, as you rightly pointed out in the end, where does this leave us in terms of, how we incorporate it into our regular protocols? How are we going to, kind of get it into a scenario where it becomes a part of our regular assessments in all the cases? With the current scenario that we have in the country, it does not seem to be really, reaching that stage at the moment in India. But worldwide, if you see, majority of the places have kind of moved into that direction. The other aspect is where again you have pointed out very beautifully that when you do not have the release of protein into the serum, for us to pick it up very clearly on mass spec will become a challenge. For example, if you have the so-called non-excretory myelomas and other plasma cell disorders where you do not have excretion of the protein into the system, then obviously you will not be able to pick it up. But what it scores very clearly and beautifully over is the regular serum protein electrophoresis and the immunofixation electrophoresis in the same context, where we have both of these tests being done parallelly, and you are obviously mass spec is giving you a much better identification of the protein. What was again very beautifully shown in these in the presentation itself is how it was eventually even giving you a prognostic indication with respect to how the curves were, the progression-free survival was also being affected. So therefore, looking at the mass spec based investigation, I would rather put it very beautifully in the picture where we're talking about a high positive predictive value, but whenever we'll have a negative, kind of a test, we may not be very sure as to whether it's going to be correlating equally with the flow cytometric results or eventually even by NGS at some point of time. I think that's my take with respect to the whole thing. I will leave it to Dr. Naomi to take it further from there and give us her insights into the thing.
So thank you very much for the invitation, and so I just wanna say that that my opinion is that the paper has been very well presented. And what else can I comment about the issue? So I guess I can address a little bit the question that you introduced. So in terms of so how we are using mass spectrometry today in Spain, so I can say that it's being very complicated to integrate it into the routine practice. Actually, we are only using it in cases that become immune fixation negative. So it's true that mass spectrometry is costly as of today. So and even so it's costly everywhere. And serum protein electrophoresis and immune fixation are cheap in Spain, and I guess everywhere in the world. So yeah, it has been difficult to introduce it into the routine practice. And as of today, we are only doing it, as I said, when immune fixation has become negative. So that's the first thing. So what else can I comment about this? So basically, so as you know, so previously we published in Blood Advances a few years ago, so the comparison between mass spectrometry and immune fixation. So we and others have shown that mass spectrometry is more sensitive as compared to immune fixation. It depends on the paper that you check, but at least between 20% of the patients are immune fixation negative but mass spectrometry positive. And the important thing is that these patients do worse as compared to patients. So these immune fixation negative mass spectrometry positive cases do worse in terms of PFS as compared to mass spectrometry negative cases. So there is another group of patients that mass spectrometry identifies that we do not identify using immune fixation, and that have a significantly worse outcome as compared to mass spectrometry negative cases. So I think this is something that it's, I would say, accepted by the community, and that well, I guess so it has been taken into account. The introduction of the method in the routine practice, it depends on many factors, and of course one of the main factors is the cost of the method, and that's I guess that's going to depend on the availability of the method. So it depends on the availability that the companies that are developing them, offer to the different countries, to the different hospitals. So that's a very important factor. So what else can I comment? So as compared to, I guess, we and others have shown the higher sensitivity and clinical value of mass spectrometry. So the next step is to try to compare mass spectrometry, of course, with MRD methods in the marrow. So we have compared our results with NGF in the marrow, which is the method that we use. And in this paper, we have shown that mass spectrometry has false positive results and false negative results as compared to NGF. So false negative results of mass spectrometry as compared to NGF are due to the fact that mass spectrometry is less sensitive as compared to NGF, no doubt, especially at the lower levels of MRD detection by NGF. So I guess, it's true that in this paper, we have not used the analysis of the free light chain. So because, the company is developing these beads, so we did not have the opportunity of using them to analyze these samples. And we think that, the introduction of these beads in the analysis would increase the sensitivity of the method. So I guess to be comparable with MRD in the marrow, mass spectrometry needs 1 log more of sensitivity. So I guess, the analysis of the free light chains would increase the sensitivity, and also if another, pre-analytical modification can be introduced in the procedure, such as liquid chromatography or similar. So it could be that, mass spectrometry would increase its sensitivity 1 log higher, and would be at that time, in that situation, could be fully comparable to MRD methods in the marrow. So it has false negative results. It also has false positive results due to the clearance of the monoclonal protein, and this mostly affects to IgG cases, because the IgA and and light chains have another type of clearance. So these IgA and free light chains are less affected by the delayed clearance of the monoclonal protein. So those are I would say that the limitations of mass spectrometry as compared to NGF or NGS methods in the marrow. And I don't know what else can I comment. So another challenge that we are facing is the standardization of the method. So we are working on that to try to to confirm that actually the results obtained from different hospitals with the same machine are fully comparable, which I think is very important. So we are working on that. And we are also working on the because we have analyzed just so positive, negative, just a qualitative result. But so using this approach, the extend approach, you can also quantify the level of the monoclonal protein, of course. And we are also working on this, on trying to to find out what's the value of quantifying the monoclonal protein using this more sensitive approach. And I don't know, that's what, so I could also comment that, as compared to NGF, so NGF does not need a baseline sample to follow the MRD in subsequent samples, as you know. So we can assess MRD in the marrow of our patients without a baseline sample, but so mass spectrometry needs a baseline sample, so a sample with a monoclonal protein that we assess at diagnosis, or at a certain time point at which the patient has a significant amount of monoclonal protein to identify the mass to charge ratio of the monoclonal protein. And then, because that is the fingerprint that then we identify in the following samples to identify the presence of residual disease. So that's another important question, I would say, as compared to NGF. And another, something that it favors mass spectrometry as compared to NGF is the fact that you do not need to analyze the sample, right away, as it happens with next generation flow, that you need to analyze the sample in the first 24 hours, especially if you're analyzing MRD. With mass spectrometry, we can freeze the sample, and then we can analyze it when we can, or we have the chance. And the last idea that comes into my mind is that it's true that so we think so discordant cases, mass spectrometry positive, NGF negative cases could be due to extramedullary disease. And this so this is an important thing, and so we are also trying to get data to document this, so to try to see the potentially complementary value of mass spectrometry and imaging methods such as PET-CT, to see if these discordant cases, at least in part, can be due to to extramedullary disease that we do not identify with NGF or NGS in the marrow just because it's due to extramedullary disease. So yeah, that's.
Thank you. Thanks so much, Dr. Naomi, for describing the finer details. I think we can take a few questions from the audience. Dr. Uday, you have a question?
Yeah, thank you, Dr. Ganesh. So firstly, I would like to compliment Dr. Akshaya and also the expert comments. I've got few comments for Dr. Naomi. So firstly, I think when we are talking about the inferiority or not the very best results as far as mass spec in this particular study is concerned, I primarily feel that was possible. That was possibly because the binding site used sheep-based antibodies. And whereas the mass fix and whatever has been developed by Mayo Clinic, they use camelids. So the sheep has an inherent problem of having lack of lambda light chains. So because of that, the assessment technique itself is compromised. So maybe if we use mass fix and if we use camelids for identifying the proteins, so that would probably give a better better sensitivity, specificity, as well as the positive predictive and the negative predictive value. That's comment number one. Comment number two, when we are talking about mass spectrometry, we are talking about clonotypic peptides and the top-down and the bottom-up approach. So when we are doing mass fix, the way the Mayo has described, that really does not require a baseline sample. We can, in fact, also assess by one-off test at any point of the study without requiring the baseline sample. And that would apply for any time of flight devices. So your comments on these 2 points, please.
So yes, so you are right. Thank you for the comments. So these two methods, EXENT and the mass fix method developed by the Mayo Clinic, are actually quite similar. But it's true that the beads that are different. One is from camelids, and the other one is from I cannot. So I guess camelids, and the other one I cannot remember right now, but they are different. In any case, so the results that we have reported using both methods are quite comparable. And you're right that in the method that we have used in our study. So we have analyzed just IgG, AM, total kappa, and total lambda. So we have not analyzed, as I said, the free light chains, because so we had not so the free light chain beads available for analysis. And I agree with you in the idea that the use of these free light chains, the incorporation of the results of the analysis of the free light chains to our results probably increase the sensitivity and probably the sensitivity of the results. So I agree with you that the method is similar but not fully comparable, and that probably the inclusion of these free light chain analysis would increase the sensitivity and the specificity of the EXENT. So I honestly don't know about the need of a baseline sample using mass fix, but I would say that I would say that you need a reference sample, because I guess the fundament of both methods is the same. So you follow the mass to charge ratio of the monoclonal protein, which is specific of each patient. So I guess you have to have some kind of reference, a diagnosis that you follow in a diagnosis, or as I said, in a time point where you have enough monoclonal protein in serum, because that's the reference that you that you actually follow in the subsequent samples. So, so I'm not sure if, that's fully, if that, I'm not sure if that's, your suggestion about the fact that using MassFix, you do not need a baseline sample. I'm not, as I said, I'm not completely sure, but I would say that you need so a baseline sample, because of the fundament of the method, right? So that's as far as the first question that you made, and I cannot remember about the second one. What was the second one? What was? Can you remind me the second?
Yeah. So thanks for that comment. So we were talking about camelids and sheep. So because binding site use sheep, and sheep inherently do not have the one of the light chains. So
yes. So as I said, they are working. So at the beginning, we use them. We use the beads for the free light chains, and it's true that they increase the sensitivity a little bit. But I guess wanted to improve the sensitivity of these free light chains and these beads for the free light chains, and they're working on that. And I guess if we will incorporate these into the analysis, as you mentioned, so the sensitivity, the specificity of the results would increase. And so can you remind me about the second comment that you made?
No, thank you. I think you have answered both the comments. So one was about the type of the antibody, and the second was based on the having a requirement of a baseline sample. So thank you. Thanks for answering both the queries. Now, I want a quick comment for the people, for the audience from the India. So most of the institutes have started started having infrastructure capability building of having mass spectrometry machines in their hospitals or their institutes. So most of the machines which are available in India are either biomuro or they are LCMS, light chain, the liquid chromatography mass spec, which we work on Orbitrap technique, which are not time of flight devices. But most of the institutes have started coming up with their own mass spectrometry evaluations for myeloma, so which does not work that way. So people, whoever wants to start mass spec from the country or from various audience, so they need to understand it has to be time of flight device, and the assessment of mass by M by Z ratio has to be taken into consideration before analyzing their results and reporting their mass specs. So it's not that any instrument can start evaluating on that. So as you rightly brought out, standardization is very important before starting reporting of the clinical or the bedside patients. So thank you. That's all from my side.
Yeah. So just so I want to emphasize the fact that we have used this method, and there are other methods to assess to apply mass spectrometry to follow the monoclonal protein in our patients. So in patients with myeloma or other disease or other plasma cell dyscrasia. So I guess our method is the one that could potentially be incorporated into the routine practice more easily, due to the fact that it's more, I would say that it's easy to implement. See, we don't talk about the cost, because everything is automatized. So you just need the sample, and then the machine does all the processing, and there is a software that analyzes the results. But in any case, there are another options, and so these other options based on the clonotypic method so are more sensitive. So we know that there are data regarding that. They are more sensitive, but it's true that they are so technically more complicated. So you need to have you need to sequence the gene of the immunoglobulins and then so from the sequence of the immunoglobulin gene rearrangement, you have to deduce the sequence of the amino acids that you are going to follow in the patient. So either from the tumor cells or from the monoclonal protein in the serum, you have to identify just a very small part of the monoclonal protein that you're going to follow in the subsequent sample. So that's very sensitive, very specific, but it's technically complicated. And it's true that we do not have clinical data as of today regarding the value of that. So just to confirm that actually we have used a mass spectrometry method, but there are others more sensitive, technically more complicated, And we do not know what's going to be their clinical value in the plasma cell dyscrasia field, because we do not have clinical data as of today.
Ganesh, can I ask a question? This is General Nair here.
Sir, please, sir. Yeah, please, sir. Go ahead.
Dr. Noemi, good evening. This is Dr. Velu Nair. I work in Ahmedabad as a hematologist. A very nice paper and very stimulating comments that we just heard. I'm a clinician, so I have some basic questions to take it to the clinic. One is in the follow-up, it's very interesting that the IFE negatives in certain percentage can be MS mass spec positive. Now, I'm interested in the levels of interventions which I do in maintenance. So if it's MRD negative consistently, I mean, we just saw an algorithm which said after 3 years, you may wait and watch and stop the treatment. So if that be the case, how frequently will you monitor when you stop the treatment for a recurrence or a relapse or the monoclonal proteins coming up again? So what are the time points you would suggest in such a case where is MRD negative?
Okay, so I guess this is the eternal question of the stopping the maintenance. If at which time point we could stop maintenance treatment in our patients. So thinking about the cost, about the potential secondary neoplasias of your patient is going to be refractory to len or bortezomib len if you're using that for high risk patients. In any case, so I can say a couple of things regarding this. So the first one is true that we have data from our group, from the Spanish myeloma group. So they have been published in Blood. So and in these they come from this GEM 2014 trial. So patients receive 2 years of maintenance, Lendex versus Lendex ixazomib, and then if patients were MRD negative, the treatment was stopped. If positive, the treatment was continued for 3 more years. So I'm sure you are aware of the results, but basically, so MRD negative patients, so basically they did not relapse, or they relapsed very, like very few of them relapse after stopping the treatment. So after 2 years of maintenance treatment, if they were MRD negative, so even high risk patients. So in that in the upper part of the curve, so they did not relapse even if you stop the treatment after 2 years of maintenance. Whereas if you were MRD positive, despite the fact that we continued the maintenance treatment for 3 more years, so patients continue to relapse. So I guess, in our studies, only 2 years. I'm sure you're aware of the results of the UK group that they have results after 3 years of maintenance. But I guess in that time frame, 2 years, 3 years, I guess if you are negative, and even more if you're sustainably MRD negative after 2 or probably 3 is even better, but our results are with 2 years. If you are MRD negative after 2 years of maintenance, sustained MRD negativity even higher, I guess you can stop the treatment, because the chances of relapsing after 2 years, even if you are a high risk patient, are very low. So, and on the other side, if you are MRD positive after two years of maintenance, there is no point of continuing the treatment, because you continue relapsing no matter you maintain the MRD, the maintenance treatment. So I guess we learned that from that study from Laura Rossignol from our group. And I always I always say when I'm asked about this, that I guess this cannot be taken as a dogma, but at least you can take it into account. I have a few patients that they tolerate very poorly the lenalidomide. They have GI problems and asthenia, cramps, and so I remember about the lady. So 2 years after 2 years of maintenance, she was sustainedly MRD negative. So neutropenia, GCSF every month. So decided to stop the treatment, and thankfully so far she's doing okay. I know that is only one example or 2 examples, but I guess
Sure.
And in terms of how often I would repeat the mass spectrometry to identify relapses, I don't have like a
algorithm.
an algorithm, but I would consider every 2-3 months to identify the presence of the monoclonal protein again. And if that happens, the patient is going to relapse in less than a year. So that's another information, clinically relevant information that we have gotten from this study, that the reappearance of the monoclonal by mass spectrometry means that your patient is going to relapse in less than a year. So I guess you could take clinical decisions because you know that your patient is going to relapse in less than a year.
Thank you so much. Thank you so much. That answers what I was asking. Thank you very much.
Thank you, sir, for the question, and thanks, Dr. Naomi, for the nice explanation. I think it's time to move to the next section. I and thank once again the presenters, presenter Dr. Akshaya, and both the experts, and Dr. Sumit now will take over. Over to you, Dr. Sumit.
Hello, sir. Am I audible and visible?
Yes, Dr. Sumit, you are audible and visible.
Okay. Thank you for the nice journal club presentation, Dr. Akshay, and the insightful discussion. So the Eagle Eye competition article, journal scan article for December 2024 was primary plasma cell leukemias displaying translocation 1114 have specific genomic, transcription, and clinical features from the French group. Just to allude the process to people who have joined this for the first time or are new to this, a specific article is chosen by the myeloma experts. We invite a commentary of 175 words before a deadline to us. Anyone who's interested, irrespective of designation, can send a commentary, and the best commentary is selected by a team of blinded reviewers. The winners get an opportunity to present this in front of a very good audience, and in the bargain also get Image a lifetime membership worth rupees 5,000. So the purpose is that all of us should read latest articles on plasma cell dyscrasias. The junior faculty and students should learn the art of critical appraisal, refine the art of scanning an article. This will encourage more letter to editors from our country, and at the same time, we'll get an opportunity to present in front of a national and international audience. So the basic points on which they are analyzed are the summary, the title, the abstract representation, author's core assumptions, the critical word limit, which is very important, some errors in the author's interpretations and facts, some ideas which may be over or underemphasized, statistical methods, and finally coming to a final score based on the references. The most important points are you should stick to the word limit, being clear and still convey a critical analysis, and concentrate also on the methodology and statistics, which at times we do ignore. So firstly, I'll thank the reviewers, Dr. Anil Handusa and Dr. Karthik Bomanan from Delhi and Chennai respectively, who helped us in reviewing this month's commentaries. So before I announce the name of the winner, a special mention for Dr. Meghna Yadav. She is currently a senior resident DM Hematopathology, AIIMS, New Delhi. Her commentary was good, but unfortunately it was received 8 hours after the deadline. Hence, it could not be the winner. The winner for today is Dr. Sashwata Saha. I am happy to announce his name because he is an alumnus of Tata Hospital, Mumbai. He is recently joined as a junior consultant in clinical hematology and cellular therapies at the prestigious Tata Medical Center, Kolkata, which also happens to be the venue for Indian Myeloma Congress 2025. So Sashwata has won this the third time this year, if I am correct. And I over to Team Mice Ideas for displaying his commentary. Nirav, we can share the recorded commentary.
Yes, sir, we are sharing it.
Good afternoon, respected teachers and my dear colleagues. First of all, I would like to thank Team Image for giving me this opportunity. Today in Journal Scan, I will be discussing brief report titled Primary Plasma Cell Leukemias Displaying Translocation 1114 Have Specific Genomic, Transcriptional and Clinical Features. As we all know, plasma cell leukemia is a rare and aggressive form of multiple myeloma defined by presence of more than 20% of plasma cells or plasma cell count greater than 2 into 10 to the power 9 per liter. Recently, IMWG consensus guideline includes presence of 5% or more circulating plasma cells in peripheral blood. It represents 2 to 4% of multiple myeloma cases, and majority being primary plasma cell leukemia and the minority being secondary plasma cell leukemia. Compared with multiple myeloma, primary plasma cell leukemia displays a distinct biological and clinical features. They have younger age at diagnosis, more aggressive presentation with frequent extramedullary disease, and fewer lytic bony lesions. Primary plasma cell leukemia have a poor prognosis with a median overall survival between 18 and 36 months. Biological knowledge, especially the molecular process responsible for its aggressiveness, is lacking because of low incidence and heterogeneity. The aim and objective of the study was to describe the genomic and transcriptomic landscape of primary plasma cell leukemia and to determine if translocation 11-14 subgroup displayed a specific genomic profile and a better clinical outcome. So for the first part of the study, 90 patients were evaluated between 2014 and 2020 with DNA and RNA sequencing, and for the second part of the study, 128 patients were evaluated between 2000 and 2020. If you look at the results, patients with primary plasma cell leukemia had higher incidence of translocation 11-14 and translocation 14-16. They had equal incidence of translocation 4-14 compared to multiple myeloma. The patients with primary plasma cell leukemia had lower incidences of hyperdiploidy and trisomy 5. Patients with primary plasma cell leukemia had higher incidences of secondary adverse lesions, including deletion 17p, gain of 1q, and deletion 1p 32 and TP53 biallelic mutation. The gene expression profile distinctly identifies primary plasma cell leukemia and multiple myeloma. The genes frequently upregulated are FAM72D and TOX2, and the genes which are frequently downregulated are DKK1 and CSF1. If you look at the gene set enrichment assay, the genes involved in the cell cycle, spliceosome complex, and fatty acid metabolism are upregulated, whereas the genes included in extracellular matrix, cell adhesion, vitamin B12 metabolism, and KRAS signaling are downregulated. If we look at the translocation 11-14 subgroup, they had a lower incidence of gain of 1q, deletion 1p32, and complex adverse mutations. The overall survival was significantly better in the translocation 11-14 subgroup, which was 39.2 months versus 17.9 months. If you look at the gene expression profile, the translocation 11-14 has a distinct gene expression profile compared to non-translocation 11-14. They have upregulation of genes including PMAP1, CCND1, BCL2L15, PAX5, CD79A, and downregulation of BAC1 and BCL2L1, which signifies a possible role of BCL2 directed therapy. If you look at the gene set enrichment assay, the genes involved in NRAS signaling, KRAS signaling, cell cycle, cell adhesion, and extracellular matrix are all downregulated. Coming to the limitations of the study excludes primary plasma cell leukemia patients with 5 to 20% of the plasma cells. None of the patients in the study received daratumumab-based quadruplet, and hence the effect of daratumumab on primary plasma cell leukemia genomics could not be evaluated. The study does not report whether transplants can negate the impact of any adverse genomic signature. The study does not give an idea regarding possible therapeutic targets in non-translocation 11-14 subgroup. To conclude, this is the largest series of patients with primary plasma cell leukemia reported so far. The study demonstrated that primary plasma cell leukemia has a specific genomic and transcriptomic landscape that may explain its biological and clinical features. The study described the biological and clinical specificities of translocation 11-14 primary plasma cell leukemia, supporting the use of novel therapeutic approaches such as BCL2 inhibitors. With that, thank you, Merry Christmas, and a Happy New Year ahead.
So this was a recorded commentary. Thank you, Sashwat, for the Christmas message also. So coming to the next month's Journal Club article, we do have the Indian Myeloma Congress 2025 at Tata Medical Center, Kolkata, from 10th to 12th January. But at Image, we don't like to spare you from knowledge. So in 23rd January 2025, we again have a webinar as scheduled on the 4th Thursday. The Journal Club article for next month is more than 2% circulating tumor plasma cells define plasma cell leukemia like multiple myeloma, again published from the Spanish group. This journal club will be presented by the Hematopathology Department Team ACTREC TMC by Dr. Prashant Tembre sir and his team. The journal Scan article for next month for Eagle Eye competition will be Definition and Clinical Significance of MGUS-like Phenotype in Patients with Monoclonal Gammopathies, again published in JCO 2023 by the Spanish Bethema Group. A special announcement for the DM students or DNB students who are watching this. We have a myeloma quiz in Indian Myeloma Congress in 2025, 10 to 12 Jan. And those who wish to register, who have not yet registered, can please go on this link and do the needful. A special thanks to Sebia and Johnson & Johnson for the educational grant for this webinar. Thank you, and over to Dr. Nitin Yashas for the quiz.
Thank you, Dr. Uday, Dr. Sumit, other members of the Image, and all the organizers. This is the Boxing Day quiz. We have the Boxing Day test matches going on between India and Australia and South Africa and Pakistan. But this is the Boxing Day quiz, a good tradition to continue perhaps going forward, irrespective of whether it's a Thursday or not, and maybe have a grander prize for a special edition quiz. Right. So for those of you who are watching the quiz, next slide, please. This 5 questions based on the Journal Club article and the Journal Scan. It is single answer MCQs. Remember, it's important to not only be fast but also accurate, like Bumrah is, to try to win it as such. So at the end of the quiz, if there are people who have the same answers, it's the ones who have given it faster who are going to be declared the winner. So 5 questions, 1 trivia, 2 on JC, and 2 on the Journal Scan articles. Right. So next slide. So if all of you guys are ready, we will start the quiz in. So you have about 30 seconds to answer each question. Your first question is, let's talk a little bit about history. Who coined the term plasma cell? It's actually believed that he was actually describing a tissue mast cell, whereas the accurate description was by Kajal. Was it A, Waldeyer, B, Waldenstorm? Was it Virchow, or was it Bence-Jones? 20 seconds left on the clock. Who actually coined the term plasma cell? A lot of pioneering names who have led the way in the field of myeloma and plasma cell disorders. Right, we move to question number 2 now, and this is from the article on the Journal Scan article. Which of the following statements is not true? Remember, which of the following statements is not true about the genomic landscape of plasma cell leukemia versus myeloma? Is it higher incidence of 11-14, higher incidence of 4-14, lesser incidence of hyperdiploidy, or lesser incidence of trisomy 5? Very beautifully brought about point by the commentator, and if you had paid attention to that, this should be a full toss to hit for a 6. Remember again, don't make it a googly. Which of the following is not true? All right, moving half-pace stage now to third question. A very simple one, actually, if you had paid attention. We know that the other mutations had 11-14 had a better survival, but what was the overall survival in patients with plasma cell leukemia without a T11-14 mutation? Do we talk about it being 10 months? Do we talk about it being a year, 18 months, or 2 years? We know that 11-14 in the article showed a very favorable PFS, or rather OS, but what was the OS in those without a T11-14 mutation? All the other mutations were grouped into this category. What was the overall survival in such patients? All right, penultimate question, try to hit it for a 6. The highest concordance between the 2 methods of assessment of the M protein in the MRD was seen in which scenario? Remember, you're comparing mass spectro versus a NGS-based testing. So in which scenario was the highest concordance seen? Was it A, post-induction, B, post-ASCT, post-consolidation, or post-maintenance? Slightly tricky one, but if you had paid some attention to the numbers, and based on the wonderful discussion that we were privileged to have with the first author, and also the question asked by Velu Nair sir, you would be able to crack this. The highest concordance was seen in which scenario? Right. The last question, what was the median PFS of those who were MRD positive post-induction by either the mass spectrometry method or by NGS? We know MRD plays a major role, but surprisingly, both the methods, if someone was MRD positive, what was the PFS seen? Last ball sixes are famous, or a last ball catch is famous. Let's see who has turned it in their favor. Right, with that, we come to the end of the quiz. Time for answers while the backend team tabulates your score. So the first question answer is, it's not Bench Jones. It is, in fact, Waldeyer. Waldeyer was the one who actually first coined the term plasma cell, but it was actually, he was describing a mast cell, and it was not the actual plasma cell. Very, very interesting stories filled with the history of myeloma, which when we go back in the pages. Question number 2. Right. Very clearly, it was mentioned in the commentary also that plasma cell leukemia has a higher incidence of 11-14, but the incidence of 4-14 was roughly the same between both the groups, and of course, they display a lesser incidence of hyperdiploidy and trisomy 5. So the correct answer is a higher incidence of T414 is not seen in plasma cell leukemia. Right, next question. And very typically, we know that the PFS in those with 11-14 is much better, as can be seen in this curve as well. Whereas in those who had who did not have a T11-14, the median survival was much lesser, and it was about 17.9 months, approximately 18 months. So 18 months is the correct answer. Right, next question. Right, now the highest concordance between the two methods was seen actually in the post-maintenance, when there was almost 85% concordance between both the methods, and that is indeed the correct answer. And like our reputed author of the paper said, post-maintenance, if someone is still MRD positive, there is no point in continuing treatment, and if they are negative, we can of course stop treatment. And it was very clearly seen that the concordance, that the NGS sort of picked up slightly more MRD positivity than compared to the QIP method. Right, last question. And the answer is that the median PFS for those who were MRD positive, either by QIP or NGS, was approximately 6 years. So I hope that most of you were able to hit this answer for a 6 and get the answer right with 6 years. With that, we come to the end of this quiz. I hope it was a learning experience. I learned a lot by attending the journal club and the journal scan. Over to the organizers and Dr. Sumit to declare the winners.
Hello, Sumit sir.
Yes, Nirav.
Sir, the winner's name is Bharani Dharan M from Apollo Hospital, Chennai.
Can you please repeat the name?
Dr. Bharani Dharan M from Chennai, Apollo Hospital.
Okay. Ganesh sir, over to you.
Okay. So as we come close to the closing session, so I'd like to thank all the attendees as well as the panelists. Special thanks to the presenter, Dr. Chair, and then both the national and international experts. A special thanks to Dr. Naomi for joining us during the holiday season. And also our the sponsors for this session, Sebia and Johnson & Johnson. And of course, MISA Ideas, people behind the scene. And special thanks to the image team, Dr. Uday, Pankaj sir, and other senior members. And special thanks to Sumit as well. And thanks for the wonderful discussion and the insights. I learned a lot, and I'm sure all the members, both in the attendees and panelists, gained something from this meeting. And over to Dr. Sumit for the next announcement about the next session.
Nothing is left. It's just that the date of next webinar is 23rd January 2025, and hope to see majority of you all in Indian Myeloma Congress 2025. Thank you.
Okay, thank you and Happy New Year to you all.
Thank you and Happy New Year to everybody.
Thank you and Happy New Year to everyone.
Thank you. Thank you. Bye-bye.
Bye.